is. Here we go. So Heather is also a board certified patient advocate. She is the surgical program director of the Center for Endometriosis Care and renowned board certified healthcare advocate and disease educator. She has focused on bench to beltway to bedside efforts in research facilitation, legislation and policy reform, education, patient-centered care, and more for over 30 years. But importantly, is someone who has personally struggled with the disease as well. Her lived experiences bring a unique perspective to her professional works and fuel to continue her passion to effect change on the way endometriosis is researched, treated, and publicly perceived. Heather volunteers her time to several collaborative endeavors, serving as a board director, advisor, editorial board member, and appointee for various journals, legislative working groups, councils, committees, special interest groups, and other organizations, including as a reviewer for various federal medical research grant programs. She continues to present on the disease internationally, as she will be doing this evening, and has contributed to countless books, articles, and publications on endometriosis and related health concerns. Her priority focus remains on ensuring stakeholder representation in all places where decisions about endometriosis are being made in order to improve access and outcomes for the future. Let's everyone give her a round of applause.
You're way too kind. She really hyped me up.
I can't help it. She's my mentor, y'all. Go ahead. You can take it away. And before we start, I do want to mention that we are going to hold all questions until the end. And because we're talking about advocacy this evening, no medical questions. Thank you.
All right, let's give it a shot. I am going to share, if I may. I am going to assume that everyone can see these slides. If not, somebody else. A couple things I wanted to really just start off with. This is a long deck, so there will be a lot to get through. Feel free to get up, walk out, if you need comfort, etc., food, snacks, whatnot. Nobody here will be offended if you, have to log off or step out or what have you. So with that, I will take it away. We are obviously going to be talking about advocacy tonight, but there is no advocacy without gratitude. So I would definitely like to give very special thanks to the hosts tonight. They are near and dear to my heart. The work they do, all of them, is just so fantastic. And it's really just truly an honor. So thank you for letting me come to the end of your series for the summer. And I'm really looking forward to your next series. And I will be in attendance at all of those because you are doing fabulous work. So everybody, please check them out. If you're not already, please follow them, get involved in the efforts. Great, fantastic resources. So thank you. Now, this is, despite being a very long deck, this is really only half the version of a full professional course. If you are a BCPA and you are short on credits or you need credits, you can head over to the Alliance of Professional Health Advocates. They do offer a full in-depth endometriosis course, which is approved for CEU credit. I am not selling it. I do not make any money. It's just an option to let you know that it's out there. Obviously, I have standard disclaimers, disclosures, and inclusivity statements, which I wanted to just briefly touch on. My sole employer is the illustrious Ken Sinervo, who I am just thrilled to have been with for the last 18 years at his amazing center. I have received honoraria for participation in meetings not related to gynecology for the ICER Council. I have no other financial relationships to disclose. Sex assigned at birth is not always consistent with gender identity. It's very important for me to recognize the whole endometriosis community and everyone with the disease. Unfortunately, the literature has not caught up yet, so there may be reference to women or women's health in citations or study references that are touched on. Please know that that is not intended to trivialize or limit the scope of this disease to the essentialized category of women. I try to use inclusive language where and whenever possible, obviously educational purposes only. And let's move on to the objectives. So we can't talk about advocacy for endometriosis without talking about endometriosis first. So I am going to touch on a few points about the disease. And really then we're going to dig into the vital role of health advocacy in facilitating faster diagnoses, we would hope, better outcomes, hopefully, increased health literacy, and reshaping and expanding the clinical research, which is so drastically lacking. And really about enhancing public disease awareness and how we do that as advocates and some of the things that we can do. Now, if you want to just take a second to read this statement, this really resonated with me. Individuals suffering from the disorder experience devastating effects on their quality of life. It impacts both their physical and mental health, even the ability to perform simple everyday tasks. But it's not just the person with endometriosis, it's also everyone around us, partners, family, and work colleagues. So this is not just some trivial disease, although many in the medical community and in our lives in other capacity really want to minimize or trivialize the disease. It has far-reaching impact, and certainly I don't need to tell anybody here that. But if there's some folks listening who don't have endometriosis and are just here to learn more about it, please know that it really does impact the whole sphere. So to begin, obviously endometriosis is not a new condition. This is not something that has just sort of cropped up, in the last few years. It really dates back basically to ancient times. However, it's really credited, the quote unquote modern credit goes to Karl von Rokitansky back in 1860. And when we talk about what the disease is, it's defined clinically as a systemic inflammatory disease characterized at surgery by the presence of endometrium-like tissue. Usually it's associated with an inflammatory process, and it comes with varied subtypes and clinical presentations. Folks may not have exactly the same disease. It may not present the same in every individual. And we say endometrium or endometrial-like because the lesions are similar, but they're different from the normal or native endometrium. They have a lot of differential, invasive, adhesive, and proliferative behaviors. And there's a large body of evidence that supports the idea and the concept that the molecular and cellular features of the lesions not only differ from the normal endometrium, but that the ectopic endometrium or utopic endometrium in patients with endometriosis is also different. And the result of that, of course, again, I don't need to tell anyone who lives with the disease here, but the result of that is distorted pelvic anatomy, adhesions, systemic inflammation, endometriomas, organ dysfunction anywhere in the body. And again, of course, we're talking about substantial morbidity, impact on fertility, painful sex, chronic pain conditions, and a very, very high healthcare burden. And the disease has features, particularly when we're talking about deeply invasive or bowel disease, it has features of invasion, angiogenesis, fibrosis, repeated tissue injury and repair, and links to various things like oxidative stress, microbiome, genetic factors, endocrine factors, immunological factors, environmental factors. It really is quite a very complex disease, which is probably why we still don't know enough about it to cure it. The sustained inflammatory response is usually accompanied by things like scar tissue, adhesions, neuronal infiltration, and the disease may have different origins for different types. So in other words, peritoneal, ovarian, or deeply invasive or fibrotic disease may actually be caused by a different underlying cause. And a person can have all three or one or two at the same time. And we know that it's polygenic or multifactorial, but there is a lot of differing theories about it. Nobody agrees. Things like stem cells, defective embryogenesis, dysfunctional immune response, oxidative stress, genetic predisposition, an aberrant peritoneal environment, endocrine disruptors, and the ever-present Samsons. No single theory can explain the disease in every patient. And unfortunately, again, I don't need to tell anyone who lives with the disease that there's no prevention or universal cure. There are treatments, but it is a multifaceted disease, which really, really requires a multidisciplinary approach. And it's not just a simple disease affecting a few people. An estimated 200 million individuals, those who don't menstruate, those who do menstruate. It's been found in fetal autopsy. It's been found post-hysterectomy. It's been found in those before they menstruate. It's even been found in rare cis males. I know folks like to say it's a woman's disease. There are men who have had it. We see a lot of different conditions observed with endometriosis, inflammatory conditions, multi-site chronic pain, back pain, migraines. At least 11 others have been documented, but there's also a very high association with other comorbidities as well. Gastroenterological, gynepathologies like adenomyosis and fibroids. Lots of folks will talk about PCOS, autoimmune diseases, allergies, pregnancy loss, adverse obstetrical outcomes, a lot of different ways that this disease is sort of intertwined with other comorbidities, which can also in and of themselves cause real problems. So I know that this is a sore spot for a lot of folks, myself included. Endometriosis is not a bad period. It's not just a period disease, not just a menstrual disease. It's been diagnosed in menopause. It's been found, as I said, post-hysterectomy, after oophorectomy. It's been found in those post-menopause who didn't take hormones, non-menstruators for any reason. And the pain and the dysfunction of the disease is not confined to periods. Typically, we see it in the abdominal pelvic region most commonly, but extrapelvic is not as rare as it's been held out to be. We do see it in the lungs routinely, diaphragm, liver, sciatic, the spleen, even though there's only 2 cases to date in the literature. The brain would be considered very rare, but it happened and has happened. And again, it's been identified in virtually every human organ system, and those impacts are multiple and systemic. And it really does go far outside the pelvis in every manner of speaking, really impacting quality of life, ability to take care of daily activities, sex, productivity, income, ability to work in a chosen profession. And as I mentioned, an increased incidence of adverse obstetrical outcomes, depression, mental health impact, costly, substantial healthcare burdens, and more. And a lot of the harms, unfortunately, are really compounded and amplified by a really poor intersectional system that is really working against the community. Power imbalance, stigma, racial, ethnic, sexual orientation, gender identity, age, disability, economic, and so many other biases that we face as a community when seeking care. As I said, it's not a period disease in the pelvis. These are all, and not an exhaustive list of places where endometriosis has been documented in the literature. So it's really not a reproductive disease or a bad period. And we have to get away from the notion that endometriosis just causes painful periods, or that, somehow it's just a case of we can't handle normal pain. Well, what is normal pain, right? If you do have painful periods as part of your symptom profile, which many folks do, the idea that everyone has this crippling menstrual pain and it's supposed to keep you at home in bed or away from work and away from your family and school, that's wrong. And I think Dr. Kara Jones said it best. Endo's reduction to painful periods has resulted in its normalization to the point of invisibility. We have to get away from that stigma. And as I said, it's a huge public health burden. And this is really where advocacy comes into play. We're talking about almost $70 billion a year in direct and indirect costs just in this country alone. And not that we compare it to other diseases because it's more or less important, but just to put it in contrast, when we look at the diabetes burden in a pure population, you can tell that it's anywhere between 11 and 70% higher than for the diabetes burden, depending on which study you're reading. Unfortunately, when we talk about research, the NIH still applies a disproportionate amount of their resources, i.e. funding, to diseases affecting primarily men, and often they poach diseases primarily affecting women for that funding. Endometriosis is one of those. And others would say, and I agree, it's probably a much higher disparity and dysfunctional funding system than we even know about. When we look at the Ellis study, which was a really exhaustive study very recently, which looked specifically at the funding for endometriosis, comparing it against other diseases and disorders, it was $2 a patient. And I think that we are worth more than $2 per patient. So that's where advocacy is really going to come in. And we also have to really advocate for the most vulnerable among us. And when we're talking about things like racial bias, this notion that endometriosis is rare among non-white women has led to this incredible culture of delayed diagnoses. But not only that, the way that people of color are treated, believed, diagnosed, and effectively treated, is also a problem, because we are seeing things like higher surgical complication rates. We're seeing more hysterectomy and done in an open manner versus minimally invasive. And even though the disease is not differing based on race or ethnicity, it does impact the surgical approach. And again, too, with Native American patients, they're less likely to have insurance. And even when they could access care, some studies showed that they reported less cessation or reduction of pain. So we have to be very cognizant and adherent to the principles of social justice when we're talking about and advocating for endometriosis. And the same is true for gender and sexual diversity. There's incredible cisnormative blind spots in the literature, even though the disease impacts transmasculine, non-binary, and queer people the same way it impacts cis women. They're left out of that conversation. And I've just included a couple of studies to just demonstrate for you that, again, the research hasn't caught up, but we are starting to have a better understanding and a bigger picture of that. And the same thing with the LGBT identified patients. They often feel that their care is insensitive, specifically based to their gender identity or their sexual orientation. And it's not just a problem in terms of gender or sexual diversity, but the emphasis on fertility and the likelihood of future pregnancies tends to be the priority for many providers with their patients, instead of really just acknowledging the pain and the quality of life. And teens, I am sure many of us struggled, I myself included, struggled with pain early on. For me, my symptoms began even before my period. And we have to understand that when you're telling patients you're too young to have endometriosis, you're delaying their diagnosis. And in fact, we know that the younger patients have significantly higher dyspareunia and dysmenorrhea, or painful menses pain levels, than older patients, at least in one recent study. And ACOG themselves, problematic as ACOG is, they do acknowledge endometriosis in adolescents is considered a chronic disease with the potential for progression. So we have to be very cognizant. And typically they may present early on with menstrual pain or GI pain as the first symptoms. Endometriosis should be in the back of our head and think that could be a potential for that patient. Unfortunately, no one here will be surprised by a recent study which demonstrated that at least half of patients are dissatisfied with care. No less than 61 areas of improvement were needed in the study population, and the subjects reported things like, obviously, of course, we want to reduce diagnostic delays, train more specialists, stop telling patients the pain is in their head or they're stressed out, stop judging and patronizing, and gender bias care, drugs with fewer side effects, right? We've been waiting 40 years for those. Improvement of public recognition, increasing better access to specialists, which is so inaccessible for so many people, reducing the financial impact of the disease, and so many others. So what do we do about it, right? Be the change you want to see, right? I am sure that everyone here who advocates for this disease or wants to advocate for this disease has a personal stake in it. But when we're talking about health advocacy, the definition is, in the medical profession, activities related to ensuring access to care, navigating the system, mobilizing resources, importantly, addressing health inequities, influencing policy, and creating system change. That's health advocacy. Now, you will hear a lot of times, out there, health advocacy, patient advocacy, it's not a real thing. Wrong. It's absolutely a real thing. And in fact, the roles of advocates have expanded so much over time that now all areas of care and research, including clinical trial design and funding requirements, request the inclusion of advocates. You may have heard the term patients included, or heard other patient-centered terminology when we're talking about research, enrolling in research, clinical trial design and development, things like that. You don't have to read that whole second paragraph, but I did think several points were pretty important. Patient advocacy is an important aspect of healthcare policymaking because patients are the primary stakeholders in healthcare, right? We're not just objects, we are the stakeholders. Our voices and perspectives must be considered when developing policies. And advocacy takes many forms, whether it's a public awareness campaign, lobbying efforts, grassroots organizing, which so many of the endo associations and organizations really are true grassroots. But to be effective, patient advocacy and policy must be grounded in the experiences and perspectives of patients themselves. So think for a second, what does advocacy mean to you, right? Everybody advocates in different ways, and it means different things to different people. Advocacy as agency is what a lot of us does, where it's sort of for the greater good of the community. That concept that the rising tide lifts all the boats, right? Fighting stigmas, raising awareness, educating about the disease, striving for policy change, working in the research circle, things that benefit the entire community. When I started off, I talked about things like earlier intervention, better outcomes. That's advocacy as agency. Others may feel, and the two can coexist, certainly, about fighting for themselves, fighting for their own care, speaking up for themselves or a loved one, helping to really navigate the process with more confidence, make better choices that you better understand and feel better about, less confusion and uncertainty. And of course, there's things like policy work, activism, all of that. But at the end of the day, really it boils down to advocacy being empowerment, right? That is the sine qua non of patient-centered care. That's the term that we use. And there are 9 dimensions of empowerment: control, participation in your own care, shared decision-making, support, collaboration with your providers, knowledge and understanding, psychological coping, power, and system. Those things are all what are required, whether self-advocating or advocating for another, so that the patient is making the best choices for themselves. And ultimately, no matter what role you play in advocacy, you're essentially a health activist. And we use our experiences towards illness activism, the concept nothing about us without us, right? We say that all the time. And it's really the advocates who have elevated endometriosis and are elevating endometriosis to the priority public health platform that it deserves. Patients and their family partners or caregivers are now increasingly being recognized, as I said a few minutes ago, about vital co-designers of reimagined care, what that looks like, that multidisciplinary model, that comprehensive care model. Whereas in the past, we've really dealt with a single provider model, and it hasn't gotten us anywhere, right? And you can kind of think about that in your head as, one doctor writes you a prescription, the other does surgery, the other maybe helps you with GI or bladder symptoms. Now we're really looking, and we've been pushing for the last probably 15, 20 years for that multidisciplinary model. And it's advocates that do that. Working on influencing policy, working on things like the endo school nurse kits so that we can get endo education into schools, the public awareness and education campaigns. We're on working groups. All of these things are really geared towards reducing disparities in endometriosis care and treatment. Things like passing relevant legislation or lobbying against legislation that is ineffective or harmful. Securing better funding for research, places like the Department of Defense, the NIH, the Office on Women's Health. We are in all of those spaces as advocates. And what I call endo-adjacent menstrual health education, right? Because endometriosis is not a menstrual disease, but it's a really important and relevant entry point, and that education should continue across the life course. Working with public health departments, working with med schools, working with clinical trial organizers, expanding that research and reshaping that research effort so that it looks like we want it to look, like it needs to look for us. FMIGS, which is the fellowship training, things like that, where we're trying to make the system better. So we can talk about, well, who is an advocate? Many folks work within the healthcare system. They are professional advocates. They're nurses, the doctors, researchers, et cetera, and so forth, social workers. There is one body that is accredited to certify. You heard Alicia and I both say the BCPA, that is a board certified patient advocate. There's one accredited body that you can sit for the exam with, and they can designate you the BCPA. There's informal, if you're a loved one, and it doesn't have to be for endometriosis. I mean, if you have a parent or a child or a loved one that you've ever advocated for at the doctor, same concept, making sure your loved one's care is correct and appropriate and timely. And I love this quote by Maya Angelou, and all quotes by Maya Angelou, really. I understand how you feel because I've been there myself. And we must support each other and empathize because each of us is more alike than we are unalike. And as I said, everybody can advocate in different ways. From a professional perspective, when we work within that professional sphere, typically we're talking about three broader approaches. Okay, we're talking about the sociological, the medical aspect, for those who work, within the medical community, but really the humanistic, which I feel is kind of the most important, because disease can coexist with health, and it treats the patient as a whole human. And that is something that incorporates the ever important biopsychosocial model, which has been around a very long time. And it's a concept that the disease is not just assumed as biological or just psychological or just social, but that there's an intersection and all play a role in how the person is being treated, what their lived experience is like. And we know that with endometriosis, a better understanding of the biopsychosocial situation of pain has been described historically as a really important step forward. So what do we need to advocate? Obviously, you want to have education, training, skills, credentialing, if that's important to you, but other things that are perhaps equally, if not more so important. Integrity, solid ethical base. I talked earlier about the JEDI principles and making sure that we're advocating for the most under-resourced among us, making sure we're making space at the table for everyone, a sense of inclusiveness, professionalism, innovation, respect for patient choices, for their care values, being sensitive to their cultural wishes and their belief system. Research, obviously, you have to understand analytical and methodological skills, at least to some extent. There's an entire separate segment dedicated to the financial and the insurance aspect. A lot of advocates have clients that they focus specifically on billing. Others kind of do it all. Whatever you're doing, remember that your efforts are a ripple, not an echo. Now, it's really, really important to understand that advocates do not make decisions about the patient's care. Advocates are here to shift that power balance, to supplement the care that the providers are giving the patients. It does not replace it. It's about really promoting self-care and management strategies to the extent that the patient can. Respecting the patient's rights is the cardinal rule and the first thing that any advocate needs to adopt. Respecting the rights of patients to make their own decisions, help them make informed choices. It is always unethical and possibly illegal to decide for a patient or otherwise coerce them. Now, I want to interrupt myself here because I know there's a little firestorm on social media lately with a certain physician who has talked about, advocates making too much noise and making folks think that we're the only voices and that we decide for patients. As I said, it is unethical, and it is the first tenet of patient advocacy. You do not decide for patients. And I don't know any advocates who do that. So just want to throw that in there. It's about guiding the journey. The Royal College of Physicians and Surgeons of Canada have said health advocacy is a team sport. So we're looking to mobilize resources for patients. We want to make sure that they have access to the full range of services and resources that they need. So we're making referrals, we're identifying better resources to help them. Guardians of the patient's rights. And this is particularly important if you're working in the medical setting as an advocate, representing your patient's interests, understanding their choices and standing up for their choices, promoting equitable access regardless of ability, age, race, spiritual practice, all of it. Everybody has a right to dignity and self-agency in their medical care. And it's about coordinating the care. We do not speak on behalf of patients at all unless they specifically require or request us to. But we're here to help bridge that communication gap, help them speak, help them put together their argument, if you will. It's about a collaborative effort with the patient and their doctors and their families and loved ones who are involved in their care. And talking about action plans, you may have heard the term SMART, right? Specific, measurable, achievable, relevant, and time-bound goals. And these are goals that patients decide. They self-identify, and it's our job to help them work through that. But advocacy is really important in ending myths and misinformation. I don't know if everybody else here gets enraged when you get a Google alert and, it's yet another celebrity talking about endometriosis in a way that is inaccurate or incorrect. And yeah, awareness is great unless it's wrong. And awareness of endometriosis as a disease with substantial morbidity is really important, as Dr. Young has said. And the truth is, misinformation takes away our ability to make informed choices. So it's really, really important, whether you're a professional or an association representative or as an individual, fact check it, share science-based, engage proactively with patients and help, correct, gently nudge and correct the misinformation in a way that is understandable for them to digest. Don't share misinformation. Health literacy to that end is extremely important. Health literacy is defined as people's knowledge, motivation, and competency to access, understand, appraise, and apply health information so they can make judgments about their health care and about their disease, right? It's a major, major component of advocacy. Correction of misinformation is critical. It's a core function of public health advocacy. Unfortunately, we have very, very low health literacy in general, sort of out there in the world. And it has real impact. Decreased use of preventive services or care seeking, poorer disease-specific outcomes for certain chronic conditions, adverse health outcomes, increased risks of hospitalization. There are real negative outcomes that result from reduced health or lacking health literacy. Unfortunately, in order to make those choices, we have to be able to find the information in the first place, right? So what advocates can do is really help an individual find, access, and understand and analyze the health information in front of them. And it does. It absolutely improves the health of patients with chronic diseases. Public awareness, in keeping with the theme. Correct public awareness is critical. Bringing information about the disease public, bringing attention to injustices, correcting that misinformation. And you can do that really by storytelling, right? There's no better authority on your disease than you. You can use your voice and tell your truth, even if your voice shakes. Share your journey. Talk about your real life experiences. They're very relatable. Folks will understand, even if they don't suffer from endometriosis themselves, it can resonate with someone else. And they may know somebody. They likely know somebody with endometriosis. If you have a story about a conflict, I know, recently in the past couple months, the news picked up a story on a patient's battle with insurance, because we all know how difficult it is to access care and how insurance will have you just go anywhere instead of to a specialist. Talk about it. What was the outcome? Where are you in the journey now? And you can really just contact even your local paper. It could be radio, social media, online. Pitch to them. tell them your story. It doesn't have to be long, usually only around 250 words or so. Do an op-ed. Really talk about the call to action for endometriosis, how we need better access to care, how we need improved guidelines, how we need improved standards. Human interest always has a good response, and it always resonates with the community. Generally, when you're formulating your story, you want to think about it from the perspective of what's the problem, what is the solution, or what are you trying to do, and why does endometriosis matter? Workplace and school, so important. There's an incredibly extensive and negative impact of endometriosis on work and school. I don't need to tell anybody here. Folks may miss as many as 19 days of work per year because of the disease and related pain and surgery and things of that nature. When we talk about school, we can look into things, if it's not for us or for a child or a loved one, look into things like ADA accommodations at school or work, an IEP plan, 504 plans. Does the person need scheduled breaks, maybe remote attendance, extensions on homework or work if possible, things like that you can explore. And there are certain protections in place for many employers. If they're large enough, they may be under the Americans with Disability Act. You can check with your HR department, but really look into the patient or your own workplace rights and accommodations. It may be a simple thing as flexible scheduling, maybe remote work, preferred parking, so you don't have to walk too far, job sharing, things like that. Try to be creative and think about ways that would benefit you or someone else. But it's also an opportunity to educate and inform folks around you about endometriosis. Again, a lot of people say, well, yeah, I've heard of that. It's infertility and painful periods, right? No. Fight that stigma, talk openly about it, encourage others to do the same. And if there's any doubt that we need endometriosis education and advocacy in schools, 82% of students in one study had never heard about the disease, even though 12% of them were missing days of school every month due to period pain, later related to endometriosis. 68% of them complained of chronic pain with their periods every cycle. Those who were sexually active had dyspareunia or painful sex. So it's a big deal. And it tracks back to my earlier talk about adolescence and how we really need to be vigilant so we can ensure timelier intervention, potentially diagnosis, and better care. When we talk about the bench or the clinical research side, unfortunately, endometriosis research in and of itself is disastrous, for lack of a better term. But research in general, clinical research really underrepresents older adults, women, gender discriminated folks, disabled, LGBTQ. Those are the people who probably have greater health challenges, but they're less able to benefit from the discoveries of science because they're not represented. Their health data is not being captured. So even though we have a landscape where it requires federally funded trials and research to have female participants and determine whether or not the treatments being studied affects females differently than males, women are still underrepresented in research, particularly where it comes to endometriosis research, because it's poorly funded. Many of the studies are not translational. Many of the studies are redundant. And this is a real key advocacy issue. The persistent lack of diversity in trials overall remains a moral, scientific, and medical issue. And unfortunately, we're not seeing that great of an improvement over time. So we really have to work as advocates towards dismantling those stigmas, advocating for change. Again, it's about ensuring representation for everyone at the table. When we empower communities to shape the research that's supposed to benefit them, it's going to work better for everybody. And that requires a really deep advocacy commitment to the most under-resourced among us. Policy recommendations, we talk a lot about this in terms of endometriosis legislation. Some of it is performative, some of it is really important, some of it is dead on the floor. But we're there, we're in that space. We're really working hard to make sure that the decisions our policymakers are making that impact all of us as patients, our doctors, our hospitals, our administrators, our insurance companies, we're making sure that our voices are represented there. It's really about challenging those relationships. It's about promoting health access and equity, working towards better accommodations, increased disease education, appropriations for better funding. Again, I can't tell you how tight the endometriosis research funding space is. I mean, if you have a grant application that goes out, you are going to get 100 responses. Maybe one of them will get funded. So it's really kind of an abysmal situation that really deserves millions, if not billions, of more money. Helping the powerless and marginalized communities to access care. These are all things that come out of the policy space. It's about facilitating changes to bring endometriosis to the forefront. And they don't know that endometriosis matters, so we have to tell them. So work on multiple pathways. Talk to your legislators, talk to them about their programs, community development, build a social movement. They work for you and they should be working with you. Anybody can advocate for endo policy, but it helps to be credentialed in the area and working in the space. I would not recommend kind of just starting your own effort, out of the blue. First, check and see what's in process, because there may be some in-process efforts that you can support. If not, dive right in. It may be as simple as a constituent letter. You can call their office. You can speak to their aides. You can speak to their staff or their interns. You can go to a town hall, go to a public forum. They love that. Now, I had said, I used the word lobby earlier, and I shouldn't have, because as advocates, you cannot lobby. There are certain budget rules, unless you are a registered lobbyist. So I want to correct myself and say you're really advocating, you're not lobbying. Unless there's a specific bill on the table that you are there to advocate for on behalf of a working group, you're typically going to be asking for general support. So talk to them. Do they support the issue? Are they up for re-election? Because they're more likely to support endometriosis if they're up for re-election. But look into their record. What committees do they sit on? Do they sit on the public health committee? Things like that. What bills have they sponsored? And once you've gotten that information, you are the resource. Again, you are the expert. Give them your elevator speech. Talk to them about one or two key issues in endo and why it matters. But keep it really personal. Remind them that you are a registered voter. You are their constituent. It could be a 5-minute phone call. It could be a 1-page email. Keep it brief to start with. And think about your asks, very importantly, because you'll have time, hopefully, in the follow-up to really talk to them more about whether it's an infertility bill related to endometriosis, or you want training or education, things like that. You can delve into that. But getting your foot in the door may be as simple as, look, I live with endo. I'm concerned about coverage and access to care, research funding, and public education. Where do we go from here? And advocacy at the doctor's office, so important. So many of us are gaslit and minimalized and trivialized at the doctor's office from start to finish across the whole lifespan. And I want to stress, if you are advocating for yourself at the doctor's office, you are not being a difficult patient. A good practitioner will welcome your participation in your care. Shared decision-making is key. Self-advocacy means choosing the best options for you. Nobody knows your body better than you. The doctor is going to spend a short time with you. You have to live in this body forever. And we already know that, a 15-minute office visit is just a flash in the pan compared to living with endometriosis on a lifelong basis. The lasting impact on our bodies of a lesion of just a tiny few millimeters is seismic. And I do want to reiterate, enduring and existing is not the same thing as living. As self-advocates, we can increase satisfaction with our care, balance that power differential, the white coat syndrome at the doctor's office, and it ensures that we're empowered to understand and choose our care. Advocacy is a way to get your needs met and to voice your preferences and maintain control and agency over your own life. And it is a positive predictor of patient satisfaction. And again, I said this earlier, you have a right to expect dignity and respect at all times. Insist on it. If you're not getting it, move on. There are other doctors out there. And I know one of the biggest things in our community is trying to find a doctor to begin with. There are a lot of doctors who say they can treat endometriosis, but the problem is finding doctors who can. Great place to go first is to check with support groups. Others can give you peer referrals. They may be very helpful. Unfortunately, endometriosis in our communities no less vulnerable to a lack of transparency than any other industry or community. Buyer beware, caveat emptor. Sometimes the groups can be devised, at least in part, as a marketing tool or a data mining source for a benefactor. Vetting may not mean what you think it does. So just be careful. Health grades, rate MDs, physicians cannot pay to have reviews removed from there, so those are pretty legit. You can also check into the AAGL Physician Finder and the IPPS Physician Finder. Not everybody who will be listed on those sites is a true endometriosis specialist, but certainly getting someone who is endometriosis informed is a really good start, right? And don't be afraid to ask questions. You know, you have to think about it from the perspective of, this is someone who's going to be treating me, and I have a right to know these answers, and just very simplistic ones. Do you understand endometriosis? And are they familiar with it, or do they not really typically treat the disease? They really don't know much about it. Are they know about it, but they're inaccurately informed? Oh yeah, it's a period disease. We're going to give you a hysterectomy. Are they aware of it, but most informed, maybe a little bit, but they're not very well informed overall? Or are they someone who is really informed and actively engaging in endometriosis care? They treat it regularly. They stay abreast of information and research on the disease, but also to think about who else might be involved in your care. Is it a PA? Is it a GI specialist? The nursing team? Is it a bladder specialist? What are they bringing to your team, and what is their role? Don't be afraid to ask. When you're searching for your doctor, and if you have concerns, you want to look into their credentialing or any medical legal actions, you should do that with your state board or the board where they're located. Industry ties. This is not an unimportant thing. Some folks may have differing agendas from what you think they should be offering for care, and you can find them right on open payments. Don't be afraid to get a second opinion, third, fourth, and fifth opinion. Keep your records. You have a right to correct any misinformation in them. Keep them organized. You can make formal corrections, and they have to be accepted on the other end, wherever the records are stored, at the doctor's office or the hospital. But talk to your doctor. They are human too. Talk to them about experiences that may make you feel uncomfortable or unsafe. Trauma-informed care is a thing, and you have a right to it. Talk to them before getting undressed. If you are uncomfortable or you cannot undergo any part of the exam, you have a right to decline it. And you have a right to have materials explained to you in a way you understand. When we talk about things like informed consent, which is a whole lecture on its own, you have to be able to understand what you're being told so you can make informed decisions. And advocacy doesn't end at the doctor's office. The same holds true for the hospital. They have coalitions and committees and family and caregiver councils you can look into. If you've got an issue at a hospital, if something has happened, we hope it doesn't, but if something has happened, you can talk to the patient advocate on staff there. This is very small. I know it's hard to see, but you can just go right to our website and see it. Just some more questions that you might want to think about when choosing a physician, especially in the cases of surgery. And you just go to centerforendo.com and find it. And advocacy improves our understanding of the financial and cost burden of endometriosis or any other chronic condition. Unfortunately, we live in a healthcare system that doesn't support and provide assistance for patients. So advocates are key in this regard. And there are specialized advocates that this is all that they do. Others will do some of it just as part and parcel of their advocacy efforts, but it's about understanding the costs of care, or if you've received poor care, advocating in that regard as well. What are the tests or therapies you're having? Why are you having it? Is there another more cost-effective and equivalent alternative? Help you understand your insurance. What's the appeals process like? Will the doctor's office do a peer-to-peer? Will they help you with appeals? Things like that. How about self-pay? Is there a sliding scale? Do they offer discounts? There's a lot of patient assistance programs out there as well. I've linked one here, medicineassistancetool.org. If you can't afford your medication, the companies are usually only far too happy to help you with that. Things of that nature, finding out issues on bills. If you get a hospital bill, you don't understand it, and an advocate can help you, or if you are an advocate yourself, going over that bill, looking at things like costs that are way beyond reasonable and customary for the state or the locale where the hospital or the doctor is, and fraud, it happens. Helping patients really navigate and understand the costs is key. You have to be your own advocate, as our boss says. But it does take a village. Advocates don't work in a vacuum, and neither does anybody else. We are really a community in every sense of the word, where we have to work together. So if you are getting involved in other collaborations, take a minute to think about what collaborators are looking for. They want someone who is thoughtful and engaged, someone who's listening. My favorite saying, listening to understand, not just reply. Somebody who understands research protocols, if that's the area that you're collaborating on, someone who gets the science, at least basically. If you are sitting on a grant committee, obviously you've got to have grant review experience. And a lot of times they want national advocacy experience. They do not want idea dictators. They do not want argumentative. And there is a difference between using your voice and being argumentative. Don't be afraid to speak up, but certainly do it in a way that encourages dialogue, not an argument. Somebody was misinformed. Obviously, that's not going to help the collaboration. But I feel very strongly about this, and I rant about it all the time because it's becoming a thing now, particularly in the femtech space. And I've watched this happen over the last few years. Patient labor is not free labor. Okay, know your worth, know your value. Unfortunately, in our community and other health communities, patient experts are the ones who are not being paid, or are the lowest paid, or are otherwise uncompensated. And yet they are the greatest expert at the table. And it's patient labor that is building the services that are being so successful. So it's benefiting everybody else. There's this notion that it's called career development or prestige and visibility and influencer status. Networking doesn't offset fair market value of your time to a sponsor. So remember that. And I would say to the companies, if they're out there listening, and I have said it and I will continue to say it, harvesting of patient knowledge for a patient council or any other labor and data mining platform where you're not crediting the patient or you're not compensating them for their time, they're exploiting the most vulnerable people in the process. Know your worth. If you're getting involved, everybody else is getting paid and you're not, you might want to give it a second thought. As I said when we started, be the change you wish to see. If you're a practitioner, know that you will learn more from someone with endometriosis than any medical textbook. Everybody as an advocate can work with their policymaker and elected officials on all issues related to endometriosis. Anybody can bring endometriosis to the forefront of public and political discourse. Don't be afraid to tell your story. Anybody can work towards advocating improvement in research and access to care. But the caveat there is try not to reinvent the wheel, try not to dilute the efforts. There's a lot of platforms in place where people are working behind the scenes. You don't see it on Instagram, you don't see it on Twitter, but there's a lot going on that may already be in place. So talk to other folks, see what they're doing, see where there's an opportunity to get involved in a process that's already underway. And healthcare advocacy as a rule across the board, it influences policy, it improves individual and community health, it reduces health disparities, it helps pass or do away with legislation, and it really does secure funding for various research. And again, I'm not going to couch my remarks. It has been said behind closed doors that patient-led advocacy is dangerous and or vitriolic. In fact, the vitriolic actually made it into press. And my response to that, not to be argumentative, my response is patients are the only credible narrators of their own experience. They are the ones driving the change. It's the advocates driving the change. They're not just objects of the change. They are the change. And I would remind folks that performative advocacy is not advocacy. If you're just simply checking off a box to include somebody because you have to, that's inauthentic. And a fishing expedition is not advocacy. If you are simply exploiting volunteer patient labor to data mine for the sponsor, you are not doing patient advocacy. You are data mining. So, power of advocacy changes lives, especially our own. And you have to remember, progress is not perfection, and it's okay to rest and try again tomorrow. You know, we're not going to solve the problem of endometriosis overnight. We've been at it for 100 years. We haven't solved it yet. But we can use advocacy to help improve our quality of life because we know our body best. And we have the right to make decisions about our care. We are the leaders of our own treatment team. And if you're working in this space for others, you advocate for others to make sure their rights and choices are respected and protected. And it's really about dismantling the access-related barriers to improve care and knowledge for everybody. Just take you through a couple of advocacy efforts. This needs no introduction. Below the Belt. Below the Belt is not just quote unquote sort of just a movie, but it really truly is a movement. It is tied to various congressional appropriation efforts. It's tied to nursing and practitioner education. It's tied to public health education, and it's tied to an effort towards disability access as well, which is really important. And there we are in Congress a couple months ago, doing a screening and a panel. And you would be amazed at how many political figures still don't know what endometriosis is. Nursing education, we're represented on the Department of Defense and other research funding panels. And when I said earlier about performative legislation, there are some really, really bad bills out there making their way through that contain misinformation, highly gendered language, an emphasis on fertility, things of that nature. This is not one of them. This went through a couple months ago, unanimously passed, signed by the governor. It establishes the first biorepository for meaningful research in the state of Connecticut. It also looks to educate nurses. There is a fertility preservation component, but in the sense that timely intervention is needed and to improve quality of life. Endometriosis Summit, everybody knows the Endo Summit. We go every year and we really do roar, which is the theme of 2024. So I'll see you there. And remember, as an advocate, as a person, as a human being, the final stage of healing is using what happens to you to help other people, because that is healing. And, you know, I am way past the time for endo treatment. You know, my journey with endo, at least physically for me in that regard, is very much less a priority for me over the last 30 years versus advocating for others so they didn't have to go through what I went through. And that's really what it's about. Just a couple of links. I don't expect anybody's going to write these down. I'm happy to send you these links. You can just email me, heather@centerforendo.com, or just get in touch with me out there somewhere in the world on media or what have you. Some really good links where you can check out excellent resources, folks who are doing really, really good advocacy work in the space, both regionally as well as internationally. Just take you through a couple more here. Of course, I had to throw in the political links, your U.S. Congress, U.S. House of Reps, U.S. Senate, the White House. If you are interested in credentialing, or you are already credentialed and you are missing CEUs, these are just a couple of places you can go. CUNY, Cleveland State University, Colorado School of Public Health, Johns Hopkins, Kennesaw State, various organizations. They all offer either certification or credentialing in some way or another, or they offer CEUs. If you are already credentialed, and I think we have come to the end of that, so I will stop sharing, and hopefully I made it through quickly enough where folks did not fall asleep. And Alicia, if you want to do Q&A, I'm here for it.
Yes, we'll do Q. And you did wonderfully on time. It's 8:03, so we have
Fast.
We have a good half an hour to answer questions.
All right.
I know we have quite a few people on Facebook Live. Odelia, where would we like to do questions first?
We can start here in the Zoom because I have one question on Facebook, but it is a medical question. And tonight we will not be touching any medical questions or issues tonight. We are just dealing with advocacy. So we can skip that question and go straight into the questions on Zoom.
Hey, ladies, I'm checking the chat, but we don't have any questions as well on the Zoom.
Well, now is the time to ask. Oh, can we receive
There's
a list?
one came in.
Julia
Oh.
is asking the resource list, the credentialing list.
For Julia, anything. Always.
Just mandatory.
Yes, my love. I will email it to you. I'm gonna write myself a note in red pen. And anybody else who wants that list or the links, I'm sure most of you have all of those links already anyway. Julia, links, yes, I will.
Yeah,
I will do
if
that.
you can email me to Heather, I would love that.
One just came in. Someone is asking because they came in late. They're asking if they would be able to view the slides that they missed.
Well,
Only
a
if
lot of
Ariel does her own interpretive dance. That's the only way.
The one slide I would like to request, if we could see again, the one that has the information for the course, the full course.
Yeah. Yeah. Where is
Right at
that?
the,
I think it was in the beginning. Yeah.
it was very early on.
Okay, I'm gonna drop it in the chat.
Okay, wonderful.
Thank you.
So this link that's being dropped in the chat now is for anyone who would like to have the full version of tonight's presentation.
It's a little bit different, because it's a little tiny bit older, but it's one of the few endo specific for BCPAs or anybody who needs CEU. They do charge for it. I do not make any money from it at all. It's just, I refer to it because it's one of the few endo specific ones that are out there that's approved. What I can do is give you the slides as a PDF, I think, and you can, I don't know, do you have somewhere to house them? I can give you the whole deck.
Okay.
We can talk about that. We can figure it out. But
Yeah.
yes, Ariel, I will give Ariel their own review.
Lovely. Julia says advocacy can be tiring. Heather, how do you engage in self-care to manage burnout?
It really is hard. I think there's this mistaken notion that advocacy is easy and you can leave it at the door and go home. Advocacy is messy. It's exhausting. It's terrifying. I mean, when you put yourself out there, you can really bear the brunt of some ugly, ugly people and some ugly attacks. And it gets really difficult. And it is very hard to remember to practice self-care. Because again, remember, almost anybody who's advocating for endo has endo, had endo, deals with a million other chronic conditions. I do too. You have to make a concerted effort. I have some really good friends. And they are my sounding board. They are my safe space. They keep me sane and they remind me, listen, you got to walk away. It's hard though. I'm not going to lie. I'm probably not the best person to ask about burnout because I work all the time, 24/7. But the work is important. As ugly and painful as it can be at times, it's really important. And at other times, it's really super, super, super gratifying. And so many great things have been accomplished by advocates in this space that you can't help but be excited about, sort of where we've been, where we're going. But yeah, you need to take care of yourself and you need to remember that you have a right to step away. And note to self.
Yes, you must take that advice yourself, ma'am.
You got to put your, what is it? Put your oxygen mask on first.
Yes, yes, absolutely. Hold
Oh,
on,
Allie, I see your question, Allie.
getting
um,
old. The glasses on.
Usually I bludgeon them over the head. No, I'm kidding. Yeah, how do you start a conversation with someone who doesn't know what endo is so they get the correct information? Well, of course, I immediately send them to centerforendo.com. But yeah, I mean, you know, I find that the most organic conversations are the most fruitful. Somehow or another, you get to talking to people and they're like, yeah, I've heard of that. I don't know what it is that well, or yeah, I have that, or however you end up connecting with them. And if they ask you, you know, you just think about that elevator speech. Well, you know, it's a systemic inflammatory disease, tissue similar from the lining of the uterus, but not the same. It's sort of found in other organs. It's really painful. It's a leading cause of chronic pain. It's linked to other conditions, and it's really expensive. It's got a huge burden on our public healthcare system. And that usually will either send them screaming or they're more interested in learning more. And then you can talk to them about various resources and stuff.
I see one that says, what would
Thank you, Angie.
what would you say is the best way to make legislative efforts less likely to flop and more likely to have a positive impact on the community?
Jillian Gilchrist, Connecticut Working Group. She has been precedent setting. She has led the way. Every single aspect of her bills that she has put forth have been meaningful and informed by the endometriosis community. Is it perfect? No, nothing is. You know, there's always room for growth and improvement, but she has such universal bipartisan support that she's been able to drive really, really important measures through. And it is not in any way, shape, or form performative, which so much of the legislation is. There is action, it's tied to meaningful action. It's tied to a biorepository to do research. It's tied to clinician and nursing education. You know, it's not just, well, we recognize endometriosis, which is equally as important, of course. We want the states and local government to recognize endometriosis as, you know, a huge public health burden and a painful disease. But we also need realistic action on the legislative front, and she's doing it. And she's the only one I know who is.
Wonderful. So for us, Vinci's in St. Vincent, not here in Brooklyn. Those home on the islands.
Born in St. Vincent, Staten Island. Does that count?
I know Odelia and Kemet and I have some big ideas. Where should we start first? Should we start with patients? Should we start with doctors? Should we start with the Ministry of Health? Where is the first, where should we put our first energies?
Yes. No, I mean, I think that for me, laying the foundation matters the most when it benefits and has tangible results for human beings suffering with endometriosis. I think making sure that patients are supported and educated allows them to take their care into their own hands. And from there, you can sort of grow the effort exponentially. Helping patients is priority number one. Working with the ministries, working with the legislators, the politicians, and what have you. Also important because, again, as we just talked about it, you know, for an hour, changing the policy benefits the patient, but we also have to make sure that the patients are supported first because they're living every day with the pain and the struggle of endometriosis and related disorders or conditions. We need to make sure that they're being taken care of, that they're connecting to better care or the best care that they have access to, and that they're being helped. Everything else is sort of, you know, growing exponentially from that. Working with the doctors, maybe it's a question of a doctor doing a fellowship at a center of expertise. I mean, Dr. Cinervo and Dr. Colon, they train surgeons, you know, every day. in their ORs. And that's, you know, that each one, teach one, reach one concept comes into play. Maybe it's getting them educated. Maybe it's helping them work on their bedside manner more. You know, there's different nuances, different things they can do to be able to help their patient, but also be educated. Don't be afraid to bring them articles, you know, bring them the literature from the evidence-based journals. Look, I read this. Can we talk about this? What do you think about this? And each is not sort of an island unto itself. They're all intersectional. But for me, the patient is always at the top of the pyramid. And it's going to be regional. You know, what one person can do in Atlanta or New York or California or Europe, maybe that's not the same thing for the Caribbean or, you know, the global South. It has to be regional. It has to make sense regionally. You know, you can't sort of just deploy a program that works really well at, you know, some New York hospital in, you know, a rural area where people are deciding between putting food on their table and feeding their family, or they can't get to the doctor. You know, it has to be nuanced. It has to be contextual.
I love that answer. Love. And I saw Commit clapping her hands when for bedside manner.
Oh, yes.
I couldn't control my
Oh,
face.
yes.
I emoted a little too much there.
Don't we always though? That's why people know that we're genuine. It's like
Yes.
right here.
Just right here. Odelia, we're having any questions from our folks on Facebook?
No questions. People are just liking as Heather talks. So
Oh, I'm
Oh,
gonna put my email in the comments too, so that anybody who needs the links to the resources or the BCPA CEU, you can just email me, because otherwise I'll forget. You can also hit me up on Instagram or wherever.
And that's Heather at centerforendo.com. Odelia, do you have any questions? Commit, do you have any questions?
I think you asked her the question that I was going to ask her. And I appreciate the answer that, you know, our efforts have to be regional or localized to our context, because it is quite different
Absolutely.
than the States. And
you have to meet people where they are. You know, everybody is going to have different cultural backgrounds, different physical limitations, geographical limitations. You know, you can't just tell somebody, well, yeah, you know, just go over the border to Georgia if they're an island. So yeah, it has to be very contextual.
And I do definitely agree that it has to start with the patient, with us, because
Absolutely.
we need, I'm trying to find my words. There needs to be a lot of education that happens.
Yeah.
We were actually just having this conversation as we were listening to you, in that sometimes we find that other women have been harsh with us because they do not understand our experience. And even though they may be experiencing some of the same symptoms, because we've been taught, I'm speaking as a Black Caribbean woman here, we've been taught that Black women are strong, that, you know, you're supposed to be sucking it up, it can't be that bad.
Completely.
When they hear another woman talking about her pain and her experience and about wanting things to change, it's difficult for them to understand that.
Sure.
Like, first, why are you talking about it? Because these are things we don't talk about.
Right.
So first, why are you talking about it? And second, if I could suck up my pain and
you
push on through, like, why can't, and that's what they're thinking, why can't you do the same thing? And so personally, I've had people ask me, how do you share this sort of personal information? And I always respond with, I do not want any girl or any woman to experience what I have experienced from the age of 11. Nobody 100%. should ever experience that. And so that has been my driving force. So even when people are criticizing, oh, you shouldn't be talking about it, I keep going.
You have to.
I have to,
You have
because
to.
as I talk, there might be just one person in the audience who goes, a light bulb goes off for them. And if I could just
100%.
help that one person, then I've done what I'm here to do.
1,000%. And I'm so glad that you said that, because it's really important. If we were to back down or go away or, roll up shop and disappear every time someone had a contrary
Yes.
opinion about us, none of us would be here. And that's why I said advocacy is
That's true.
messy and it's ugly. And you do need sort of, a little bit of resilience and a really, really good core group of friends that you can vent to. I mean, I can't tell you the amount of tears that I have cried, how many times I have quit, and wanted to walk out like 36 times a day. I mean, there have been concerted efforts, let's just say, really to take down what they call our type of advocacy.
Yeah.
I don't give a shit.
Yeah.
Sorry. I am here so someone else doesn't have to have 22 surgeries and
Yeah.
4 rounds of Lupron because she couldn't get help. Sorry.
And I would just like to take this opportunity, though, to talk about we call it the Caribbean Coalition. So the other groups in the other Caribbean countries. So I see Abby is here from St. Kitts and Julia, of course. And we do have Sandrina from and we do have Sandrina from Jamaica on the Facebook Live. And we have St. Lucia. I'm trying to remember, make sure I get Dominica. So we do support each other in the region because we have realized that our context is different. And so we share ideas, we support each other's programs as best as we can. Hi, Julia. And so I definitely agree with your 2 points about the regional work, because it works. Sometimes it can be overwhelming, and it really helps to talk to somebody who is doing the same kind of work as you in the same region as you, that they understand and they can, even if it's just to tell you, keep going.
Yeah, absolutely. That's so important. People don't understand unless they understand.
Yes.
Yep.
And I see that Abby. Yeah.
Abby has a comment.
Yeah, I
Yes.
see you. I see you, Abby.
So that's Abby from St. Kitts.
So yeah, it's really difficult because the easy answer to that is go to industry. They're always so happy to throw money at organizations, but there are a lot of ties that come with that. So you have to be really deliberate. You have to think about where do I want the money to come from? Or the money doesn't know where it came from and nobody cares. That's totally up to you being the organization. You can look at corporate partners. Here we have different grants and so forth. I'm not sure what it looks like for you there. That again, when we talk about anything to do with funding for endometriosis, it's such a highly competitive space that many people are really iced out of it. And that's the same with organizations too, and individual, requests. It's easier if you're an established 501c3 or have, legal standing as a quote unquote charity or a nonprofit. It's a little easier to maybe look toward partners like local hospitals, even the local physicians, local companies that are sort of non-industry, that they're there to support, but they may not be medically oriented. I don't think there's any one specific target to go after. And really it depends on the project. Is it a $5,000 project or is it a $100,000 project? Is it, we're having an event we would like you to sponsor, or we're hosting a research study. So I think it depends on the nature of it. And, it's hard. It really is so very hard. I know that most of the grassroots organizations, with rare exception, they're getting donations from patients, they're getting donations from companies, they're getting, little like Amazon sales, they get the benefit from that. People are really doing grassroots stuff. Now, on the other hand, if you're some of the bigger organizations, worth $2 or $3 million, and you've got major industry funding, of course, that makes it a lot easier. But I think just keep your eye out. Sometimes companies will put out an RFP. If they want to know, are you having an event? You can apply for it. The grants are small typically, and that's okay. Maybe we don't need 100,000. Maybe we only need 1,000. Just keep your eyes out for different ways to kind of look into fundraising and things like that. It's hard. It's really hard. I don't have a good answer because everybody's in that same space trying to get the same funding. But, keep your eyes open.
Any thoughts about NGOs for us?
About what?
NGOs for funding.
Oh, well, it depends. I mean, there's a lot of different rules that come with that. But again, it's look at the RFP, look what they're funding, look what they want to do. If there's and sometimes you have to be creative. Maybe they're going to offer a small grant for a health equity endeavor, right? You can tie that to endometriosis in a heartbeat. So sometimes maybe you have to be a little bit little more nuanced than just sort of a regular quote unquote broad endo project. Sometimes it's a gala. Endo Black has a gala. I certainly don't profess to know what Lauren's fundraising status is, but I know she's got some beautiful sponsors on her gala every year. That's a specific event that she gets support for, and rightly so. And then there's others who want to develop an educational program. So they're looking at NGOs and they're looking to industry and they're looking to other partners to kind of say, well, can you help us put this together? So it really depends, but think about the context of it and how that can be tracked back to endo. And sometimes you got to be a little creative.
Got it. Corporate
banks, yes. See, Julia knows. She knows what's up.
And there are a couple of thank yous. Thank you, Heather, for devoting your time to this presentation.
Please.
And Abby's thanking us for organizing the event. Yeah, I think that's a great place to start, corporate banks. And I think we got a good set of ideas rolling here. I know everyone's got their,
thinking cap on.
Thinking cap.
Where you are.
And the wheels turning in their heads right now about all their ideas.
I mean, if you're in a major metropolitan area, certainly you're not going to be able to walk into the mom and pop shop that sells bagels and say, you want to sponsor me for $100, right? You're going to have to go, to the Morgan Stanleys of the world and say, do you have a corporate fundraiser? How can I get involved? So again, it's really regional and local, and it depends on, meeting them where they are.
Absolutely. And I know, not just with St. Vincent, but all of the islands, tap into the diaspora, because we've got, a lot of organizations here in the States, in Canada, in the UK. We can bring them, all together for a coordinated effort. Yes, banks are good. We got some funding, and this is from Abby. We got some funding from the bank over here who gave us some funding to host a below the belt. So that was great. They were quite generous.
Excellent. Well, don't worry. I'm going to hit the lotto and I'm going to remember all of you. So it's all right.
We'll tour the Caribbean together. It'll be lovely.
It's going to be great. I can't wait.
It's 8:27. So if there are any other questions, please put them in now.
You can just contact me too, because I'll leave this Zoom and forget to send everybody everything. So yeah.
I'm always available. My DMs are always open. You can always hit me up if you have any questions about anything, if you need to get in contact with anybody from any series that we've done, any of our speakers. You can always contact Odelia or Komet. We're always open to speaking to everyone. So please, always.
Open to speaking to almost everyone.
Well,
if you
don't start. You're getting
conference. I don't want to speak to you. I actually put that on a t-shirt.
Oh my God. You're such a troublemaker.
I am.
Why
I am
we-
absolutely. Good
That is
trouble.
absolutely you.
Good trouble.
Right. Okay, we sure no one else has any questions? So we do want to be respectful of everyone's time.
Thank you for hanging out through it. I know it was a long one to get through and go over, but I think it's important that folks understand, everybody can advocate in their own way, whatever that looks like. And it really is a ripple. It makes a difference. It really does.
And Ariel says, thank you, loved every minute of it. And we thank you all for showing up. Thank you for lending us your evening. We appreciate you all. Giving big hugs to everyone who from all over the world who's joined us, even a few from Australia.
Yes, I can't believe it. It's what, Friday morning, 9 o'clock, right?
Yes. Friday morning, 9 o'clock. Thank you all. We appreciate you and have a great evening.
Thank you, everybody.
Thanks, everyone.
Take care.
Thank you, everyone. Have a good evening, and thank you so much, Heather. Thank you.
My
Thank you.
pleasure. Anytime. Anytime.
All right.
Thank you to the Center for Endometriosis Care.
Good night, everybody.
Good night.